Welcome to the Long COVID and Post-Infectious Syndrome Echo, a collaborative effort between the University of Utah and Bateman Horne Center. I'm Clayton Powers, full-time physical therapist at University of Utah and also education liaison for Bateman Horne Center. I'm joined by Sarah Day, Project Echo lead at University of Utah. And today's session will be recorded, but all participant details or sensitive information will be removed before it's shared on the website or social media. After the session, Sarah will email CME instructions and a copy of the slide deck. Please note that CME credit must be claimed by midnight tonight, and it can take up to 24 hours to appear on your CME profile. We invite you to introduce yourself in the chat and contribute with questions or comments as you feel comfortable. And you can raise your hand or unmute yourself to ask a question. We also want to remind everyone that this is a clinician-only forum, so we try to stay professionally focused. Today, we're privileged to have Todd Davenport and Staci Stevens present to us on cardiopulmonary exercise testing and metabolic dysfunction in long COVID. Todd Davenport is well known in the ME/CFS and long COVID world and has an extensive resume, including being a professor and chair of the Doctor of Physical Therapy program at University of the Pacific. He has extensive experience in clinical care, research, and education. Staci Stevens is an exercise physiologist and expert in ME/CFS and is the founder of Workwell Foundation. Workwell Foundation provides 2-day cardiopulmonary exercise testing for disability and diagnostic purposes for ME. And Staci and Todd have written several research papers together as well about cardiopulmonary exercise testing as well as metabolic dysfunction with ME/CFS and long COVID. So we're so grateful to have you here. Todd and Staci, thank you for being willing to talk to us, and go ahead and share your slides. The time's yours.
Thank you all so much for attending. This is my favorite topic. I love talking about cardiopulmonary exercise testing, so I can't wait to get into it. I want to thank University of Utah, Project Echo, Bateman Horne. Clayton, thank you and your team for pulling all of this together. And this presentation and our work would just not be possible without our amazing team. Christopher Snell, Mark Van Ness, our medical director, Teresa Dow, Karen Steer, Jared Stevens, and of course, Todd, my other right-hand man. We've been doing this for decades together. So these guys are just absolutely outstanding. So thank you all. So have you ever thought, I wish that there was a test that could? And in long COVID and infection-associated illnesses, fill in that blank. What would that be for you? We have been thinking about this for years. And what if I could? Here's what I wish. What if I could find a test? I wish I could find a test that would tell the story of my patients, that could measure post-exertional malaise, that could measure fatigue, that could measure the impairment my patients are experiencing. Well, let's talk about cardiopulmonary exercise testing. This is the answer. Our entire foundation is focused on studying the biological basis of post-exertional malaise and characterizing fatigue in long COVID and ME/CFS and other fatigue-related illnesses. Cardiopulmonary exercise testing is this non-invasive diagnostic procedure. It analyzes the responses and cooperation of the heart, the lungs, the circulation, and the metabolism at rest and during increasing muscular stress. So you get this beautiful picture of multiple systems. And in these complex multi-system illnesses, it's really helpful to identify and know what's going on. Well, what does the test measure? It's called a metabolic cart for a reason. It measures metabolism. And so it's a standard stress test with a 12-lead EKG. We add the addition of a mask to the face to capture expired air or expired gases. We have an oxygen analyzer, a carbon dioxide analyzer, a flow analyzer to measure how much air is moving in and out of the flow meter. And then we are able to look at heart rate, rhythm, and blood pressure. So we get a hemodynamic picture at rest and during exercise stress. Well, how does the oxygen think work? A lot of clinicians want to know. That's nice, but I want to know how it gets there. How do you really get these numbers? The oxygen analyzer works by analyzing room air. So we know what percent oxygen is in room air. It's about 21%. So we know what's going in, and we're measuring what's coming out. The difference is that which is used by the body, the oxygen that is consumed to produce energy. The American Heart Association says that this is the gold standard aerobic exercise tolerance assessment. Well, what is the value of this? If this is the gold standard, then every clinician, in my opinion, should know about it. This is the clinician's guide to cardiopulmonary exercise testing in adults. And what it does is it tiers you through a series of what I just told you, those values that it measures, oxygen consumption, carbon dioxide production, and whether these variables are normal or abnormal on an exercise test, and what that means. So if you'll just take the first one, high VO2 to heart rate, that's called oxygen pulse under the abnormal responses here. It's a proxy for stroke volume. So that combined with a low peak heart rate tears you into chronotropic insufficiency. We see that a lot. That's something, relatively new. We were so focused on the metabolic problems that for a long time we missed the chronotropic problems. And that's an issue because if there's preload failure, which is also a relatively new finding in long COVID and ME/CFS, there's likely to be chronotropic insufficiency, meaning you have a delivery problem. If the heart isn't beating fast enough to oxygenate the blood and deliver it to the tissues, there's an availability problem and you don't get energy. That's one limitation. It also tiers you into whether there's a heart problem or a lung problem, which in long COVID is extremely important. Is there a problem with the pump? Is there a problem with the lungs? Whether or not gas exchange is efficient, whether there are breathing efficiency issues or dysfunction. And then, oh, this beauty down here that's popping up, autonomic dysfunction. And so we get all of this. Is it an abnormal response? Is it a normal response? And then what are the general patterns of impairment? Are there oxygen extraction or utilization issues? There are over 50 conditions that can be diagnosed using these flowchart algorithms from cardiopulmonary exercise testing. Well, that's nice, but is it reliable? Is it reproducible? I pulled this table from one of our publications where we did a case series looking at a patient with HIV and a patient with MS that reproduced their exercise test results 24 hours apart. This slide shows that it is highly reproducible, looking at all of these variables at peak, oxygen consumption, ventilation, heart rate, and workload, and then looking at those same values at the ventilatory threshold or anaerobic threshold. Whether you're sedentary or you have trained people that are healthy, people with end-stage renal disease, cystic fibrosis, lung disease, all reproduce a cardiopulmonary exercise test. And that's one of the things that every exercise physiologist know. This is a reliable test. It is highly reproducible. In fact, the American Heart Association says that gas exchange measurements are highly reproducible with a given subject if testing methods are consistent. And what's the variability? They say 3 to 4%. In our test reports, we like to err on the side of caution, and we'll say 8% is within the realm of variability, but that's very, very lenient or generous. 3 to 4%, and that's in most patient populations. Well, as clinicians, you may be wondering, what's the clinical utility? How can this help me in my practice? We have found that it is very capable of identifying post-exertional malaise, the phantom symptom that nobody believes, that's elusive and it's hard to quantify. We can measure that. It's extraordinarily helpful for disability because you get an oxygen consumption that relates to an impairment category and tells you what the severity of the impairment is based on oxygen utilization. And then athletes have been using it for years uh, to guide exercise training programs. And for our patients on the other end of the spectrum, we can use it for activity management. The test provides a heart rate and a workload at the anaerobic threshold, as well as an oxygen cost. So you can determine what activities are above that oxygen cost at the anaerobic threshold. And if daily activities are putting them over, you know that they will have a problem with self-care and with work and working consistently and reliably. Research utility, we happen to also be researchers, and so it's just a fabulous research tool. It allows us to tier into all of those categories of dysfunction, to subset our patients in a variety of ways. And at any given time, if you go to clinicaltrials.gov, there will be literally hundreds of clinical trials using cardiopulmonary exercise testing as an outcome measure. Well, why haven't more people heard about this? Uh, and I think that this is the problem with this test, is that it is relevant, but it is widely underused. I thought this when I was undergoing my clinical rotations. Clinician in sports medicine is something that every exercise physiologist has to do. I went to my local hospital, to their pulmonary lab. They did cardiopulmonary exercise testing, and I said 30 years ago, why isn't everybody doing this? This is fantastic. And at that time they weren't. And I thought, well, we've got to do something about that. This quote summarizes it beautifully. Discrepancies in application are compounded by patterns in which the test is administered and interpreted by typically cardiology, pulmonology, or exercise specialists who limit their assessments to the priorities of their own discipline and thereby miss opportunities. So everyone is viewing this test through their own lens. And I think as a result, sadly, we're all missing these opportunities that this multi-system test can provide. And really, we can distinguish symptom origins. And if we can distinguish symptom origins, we can design better treatments and we can better help our patients by helping them understand what their limitations are. This is a study that we did that was a single test, cardiopulmonary exercise test, back in the 90s. And it was a multi-center study with 12 different locations. And we used peak oxygen consumption to subclassify and stratify patients based on AMA guidelines for the evaluation of permanent impairment. There's a whole textbook on that. But we found that even though all of the clinicians referring their patients to this study said their patients were severely functionally impaired, one exercise test only showed that about half the patients had moderate to severe impairment, and the other half showed no impairment or only mild impairment, even though when you compared them to their age predicted values, their actual VO2 was well below predicted for each impairment category. So what were we missing? We were missing half the story. We were missing the picture. And so our solution to that and the reason for that is that in chronic fatigue syndrome, there is this problem of post-exertional malaise, which also is prevalent, highly prevalent in long COVID. So we get the patients on the good day, they come in, they're able to do it. It's helpful for the half the patients, but the other half, we completely miss the story. And so what we did was we developed a 2-day test protocol where we bring the patients in on the good day and use this highly standardized and controlled exercise stressor to produce a defined post-exertional state, and 24 hours later bring them back to repeat the test. We followed up with a 51 patient study where we did a 2-day CPET, brought patients back 24 hours later to see what the impact was of the first day. And remember, this test is highly reproducible, 3 to 4%. And here's what we found. In the post-exertional state, peak workload in the controls actually improved a little bit. In the patients, it declined. The story wasn't at peak, it was at the anaerobic threshold. Work output at the anaerobic threshold for the controls, they knew what was coming. They were a little more efficient on day two. Things improved. But for the patients, this red arrow, there was a 50% reduction in work output during post-exertional malaise. And this is why your patients are so devastated after normally tolerated activities or exercise or being upright for too long. Post-exertional malaise shifts anaerobic metabolism 50% earlier. And that's a problem for generating energy and not having symptoms. Dr. Keller and her colleagues followed this study up with another 2-day CPET study published in 2014 that showed if you use just one test, you overestimate functional capacity by 55%. So you might get impairment, but you're going to miss 55% of it if you don't do the second day CPET. You need to capture your patients in the post-exertional state. Well, what's going on? It's a metabolic problem. It is a problem of broken energy systems when you're shifting anaerobic metabolism 50% to 55% earlier. And as a reminder, we'll go back to basic energy system production. Aerobic metabolism is extraordinarily efficient and elegant, 30 to 36 ATP per glucose molecule. It is oxygen dependent. Life is good when aerobic metabolism works. But with increasing exercise intensity, there is a shift towards anaerobic metabolism. And while you can still produce energy in that emergency system, you only get 2 ATP per glucose molecule, and that's accompanied by lactate. And when lactate builds up, you get symptoms and fatigue and dizziness and nausea. And so when this occurs just during daily activities, and it occurs 50% earlier on one day than it does on the day before, your patients in PIM are living in the land of 2 ATP with a constant byproduct of lactic acid and metabolic waste. And that's the story of post-exertional malaise from our 2-day CPET perspective. And so we set out to measure the biological basis for PIM, this multi-system integration of the heart, lungs, and metabolism, and found that we have a very clear picture of what this means. Fast forward to 2015, and there was a report beyond myalgic encephalomyelitis, redefining the illness, and the Institute of Medicine summarized our research, and they characterized our 2-day CPET protocol as an objective measure of recovery after physical exertion and as an adjunct to diagnosis in ME/CFS. They said the existence of PIM can help physicians confirm a diagnosis of ME/CFS. Further professional endorsement, just in this last year, Todd was absolutely instrumental in writing a chapter in our American College of Sports Medicine's guideline for exercise testing and prescription. That is our professional association. If you need a resource, this is an excellent resource for clinicians on guiding exercise prescription and 2-day CPET in ME/CFS and long COVID. And the chapter says it's a valid and reliable method for assessing functional capacity, documenting impairment for disability claims, and guiding pacing strategies for conditions such as ME/CFS. And the American College of Cardiology, the California chapter, also has case examples of 2-day CPET, and they provide specific recommendations for implementation and interpretation of the protocol to document functional capacity and identify biomarkers consistent with PIM. So when your patients say, "Nobody believes me," My doctors don't understand. You can say, hey, there are professional organizations that say that post-exertional malaise is not only real, but it's important. And you can point them toward these resources. What does 2-day CPET do? We go back to the beginning. It helps you objectively identify and characterize fatigue through oxygen consumption and stratify patients into impairment category. It measures post-exertional malaise in a quantifiable way, and it gives you the source of exercise intolerance. Is it the heart? Is it the lungs? Is it autonomic dysfunction? We can answer those questions. There are multiple coordinated actions to deliver and use oxygen. Again, these systems all working together to produce energy. Not all the tests have a 50% reduction, but even subtle deficits across multiple systems can produce really dramatic changes in physical functioning. 2-day CPET is beautiful because it provides both objective and descriptive measures of PIM. In the objective arena, you cannot fake this test. So as it's getting harder to pedal on the bike, you can't say, well, I'm not going to use as much oxygen right now, or I'm not going to produce carbon dioxide because I'm going to stop buffering lactic acid. It's automatic. It's really hard to cheat that test, and you get objective measures of metabolic, pulmonary, and cardiac function. It's also descriptive because the values can be compared with normative data, as well as comparing the patient to themselves one day to the next. And if they're not identical, there's a problem. In a nutshell, what does 2-day CPET do? It really characterizes well this failure to recover, and it does so in a multi-system fashion that allows you to see whether or not homeostasis was maintained. The body is really good at returning itself back to homeostasis. And when this doesn't happen, it's called post-exertional malaise. It is a complete system failure to normally tolerated stresses and activities that should make people feel good. I want to talk quickly about recovery time because you can't talk about 2-day CPAT without discussing recovery. And I was surprised to find I'm always learning new things that there's a fast recovery. So the test is designed uh, to create PIM and to quantify that. And so we did a study with 51 subjects doing 2-day CPET and found that 49% recovered within 4.5 days. And, I'll keep seeing patients recovering in 2 days and 3 days and 4 days. And I'm always a little bit mystified. There is a fast recovery group, and it's about half of our subjects or half of our patients. There's also a slow recovery group, but it's only 51% that takes 7 days or longer to recover. There was a follow-up study in 2023 through Maureen Hansen's Collaborative Research Center, NIH-funded center, and we did 2-day CPET. It was a multi-center study with 80 subjects that found the average recovery time was about 2 weeks from 2-day CPET, and only 7 to 8% of patients took 1 to 2 months to recover. So this is a conversation to have with your patients about recovery, that if they want this objective data, it is available and it is helpful, but to plan on a recovery time. And most patients know their recovery trajectory, whether they recover fairly quickly within a week or if it's going to take them longer. And to plan accordingly and to bring out those PIM busters, we recommend IV saline for all of our patients to facilitate recovery. I'm sure you have a toolkit of recovery strategies that you can provide to your patients, but keep that in mind when you're referring patients. The other thing I want to discuss is risks versus benefits, because there is a risk benefit to just about everything in life. And while this test does induce PIM and there is a chance of delayed recovery, and uh, that is very real, and we don't want to minimize that at all. We've done a whole slew of research on the qualitative aspects of PIM. you need to weigh those with the benefits. And the benefits are that unfortunately having a physician's signature or their word that their patient is disabled is not enough for disability insurers or Social Security that requires objective evidence. And when you get objective evidence for disability, you give your patients the opportunity to have a monthly check, to get a disability check as opposed to being financially bankrupt, and have the opportunity to get medical benefits and Social Security. The other thing that it provides for every single patient is simply validation, objective evidence. 30 years later, we don't have good blood markers or biological tests that provide patients with validation, severity of illness. It is also a fantastic tool for activity management and pacing through heart rate monitoring. And that's a whole separate talk. But lots of benefits, also some risks. So these are conversations to have with your patients as well. I'm going to summarize this by just saying this is a relevant test. It's valuable in long COVID and ME/CFS, but it is still really underutilized. It provides you with objective measures in an area where there are few objective measures of fatigue, of post-exertional malaise, and subsets of dysfunction. And now I'm going to hand it over to Todd to let him talk to you about what our research is saying about long COVID and 2-day CPET.
Thank you, Staci, and thanks for your long time work in this area. It's always wonderful to learn from you. I back in 2008, I think it was 2007, probably fall of 2007, my first couple of weeks here on campus, I found what was called the Pacific Fatigue Lab. And Staci was on campus doing 2-day CPETs at the time, and went over and just sort of unannounced, knocked on the door in true Todd fashion. And thankfully, she opened the door because if she didn't, that would have been awkward. But I also would not have learned nearly as much as I have learned working with Staci and with our group at the Workwell Foundation. So thank you for that, and thank you all for attending today. I'd just like to brush through about 15 minutes of some of the more recent data related to cardiopulmonary exercise testing, 2-day testing in people with ME/CFS and long COVID. And I've presented some of this work elsewhere, but really was hoping to provide a bit of an update on some of the work that Staci already has presented in terms of the utility and some of the trends that we see in metabolic and cardiovascular responses to exercise in people with ME/CFS. And so we've already known for a while now that CPET is a widely accepted method, as Staci mentioned earlier, starting to see some additional uptake of CPET, not just in terms of characterizing function, which it definitely does, but also helping as a differential diagnostic tool, especially in these kind of multi-factorial pathophysiologies like long COVID, in which you have many different types of conditions under the same umbrella of misery. And the CPET really should be repeatable between two tests administered 24 hours apart. And we think those limits are within about 6 to 8% across the board for measures at maximal exertion. We also know that the volume of oxygen consumed, which is reflective of the body's metabolism, as well as the work rate at submaximal exertion or the ventilatory anaerobic threshold, is abnormal. And particularly abnormal on the second day of a 2-day CPET in people with ME/CFS. And Staci pointed to the Snell study in 2013, which was one of the first to show that, subsequently replicated the following year by Betsy Keller's group, and again 10 years later. But also just wanted to point out that this is a finding that's been swept up into a couple of systematic reviews on the topic, and so again, not a finding that is an isolated one in small sample sizes by any stretch of the imagination. It's been replicated now in labs worldwide. And so what we wanted to find out was, does this trend of impaired recovery responses on the second CPET of a 2-day CPET protocol also hold for people with long COVID, in whom we've noted that many of whom will meet clinical criteria for ME/CFS, which includes post-exertional malaise. And so our purpose was to compare the systems level physiological responses after a prior standardized exertion, or the first CPET, in people living with long COVID compared to pre-COVID ME/CFS, and then also healthy controls. So that's what we tried to find out. And so as we go on to the next slide, here's what we did. We tested 32 women with long COVID. These were physician diagnosed. So again, it was kind of all comers that met the National Academy of Medicine's long COVID criteria, which, as you know, are extremely broad. Compared them with 61 women with ME/CFS and 51 healthy women matched ME/CFS. The ME/CFS and the sedentary healthy women data came from the MAP ME/CFS database that we downloaded. And the parent study was the Keller paper in 2024, 2-day CPET paper. We had a specific use agreement to be able to do that. And then we also had several different data collection sites. We focused this analysis on the Workwell Foundation data and not the Ithaca College data. In terms of procedure, this was laid out by a paper that Staci and co-authors wrote in 2018, laying out the 2-day CPET protocol. It consisted of 2 maximal cardiopulmonary exercise tests 24 hours apart. And we primarily looked at the analysis of expired gases at resting, at ventilatory anaerobic threshold, and peak exertion, as well as the hemodynamic responses, heart rate, systolic blood pressure, and ventilatory responses in terms of respiratory rate, and the volume of air cleared by the lungs in a minute, or minute ventilation. And so these are just sort of the standard cardiopulmonary exercise test variables that sort of get measured in these kinds of studies. And if you've never seen what this looks like, this is representative of what kind of comes off the cart, out of the computer. On the left, you have a plot of the volume of carbon dioxide and the volume of oxygen that is plotted breath by breath. And we're looking at that blue line, which is the VCO2 versus VO2 plot, and we're looking for a discontinuity in that line where you start blowing off more carbon dioxide than you're taking in oxygen, and that discontinuity is called the V-slope method. Define the ventilatory anaerobic threshold, and then you can verify that by looking at the end-tidal plots that you see there on the right side, in the pink and the pink and the blue, and then also looking at the ventilatory equivalents in the green and the purple. So looking for certain trends there. Now, you can't just sort of take one breath and assume that it is representative of the whole trend. And so we used a middle 5 of every 7 breaths averaging method to smooth out a rapid inhale or exhale or a sneeze or something like that could totally goof up your data. Clinical term, goof it up. And we also looked at standard criteria put forward by the American College of Sports Medicine to determine that maximal exertion actually took place. And we emphasized the respiratory exchange ratio of 1.1 or greater, which is the volume of carbon dioxide or the volume of oxygen at the point of maximal exertion. So good. So in terms of data analysis, of course, we calculated all the descriptive statistics. We used one-way analysis of variance to look at between groups differences for the different demographic characteristics, Pearson chi-squares for differences in proportions. And then we used repeated measures analysis of variance consisting of 3 groups and 2 tests with a Bonferroni correction for multiple comparisons. So we considered that pairwise comparisons were statistically significant at an alpha of less than 0.017. So this repeated measures ANOVA was the same methodology used by Betsy Keller's group in 2024. So what we found was that our groups were relatively well matched. Our ME/CFS group was significantly older, but maybe not clinically significantly so than our sedentary controls. Our long COVID group was racially less diverse than our sedentary controls in particular. And then the AMA impairment ratings, interestingly enough, based on the VO2, got significantly worse in both ME/CFS and long COVID. But what I want to kind of point everyone's attention to is this is based on maximal VO2, AMA impairment ratings. We were class 3 and class 4 in almost three-quarters of the participants in long COVID. So extreme impairment on the second of the two cardiopulmonary exercise tests, and sort of this shift towards more impairment in long COVID. And the same trend that we observed, maybe even a little bit less so in ME/CFS, but very much exaggerated in long COVID. And again, this is based on maximal exertion data. We're not choosing that maximal exertion, lightly. We're using an objective criterion here. So this is not symptom limited testing where the patient taps out when they feel like they're done, even though they do. We're looking at maximal testing using an objective criterion here. So this is some pretty illuminating numbers. So if we move forward, we'll start looking at some of the metabolism. Everyone achieved that maximal test result, and we did not find a difference between ME and long COVID for either volume of oxygen consumed or workload, which are the charts on the two rightmost charts, even though there were significant main effects for both patient groups and control. So interestingly, the patient groups were lower than the control group, but there was no difference in between the patient groups. And so if we move on to take a look at the hemodynamic responses, there were no significant differences in heart rate and in blood pressure at maximum exertion, even though qualitatively looked lower. These were not significant differences. So interesting. We hear about differences in heart rate and in terms of dysautonomia. We hear about differences in potentially blood pressure. Maybe driven some of these abnormal hemodynamic responses driven by microclots, but at the systemic level during a peak test did not shake out as being significantly different. When we look at ventilation, again, we hear a lot of concerns, and rightfully so, about breathlessness and dyspnea in people with ME and long COVID, but there were no differences at peak between ME, long COVID, and control in terms of objective markers of ventilation. And then if we look at ventilatory anaerobic threshold, we see, again, some significant main effects, large and interaction effects. So again, a significant decline between test 1 and test 2. So the rate of decline was significant, as well as the magnitude for both patient groups compared to control. And that's both VO2 and workload. So this is something that we've seen for years in ME/CFS and long COVID. And it's shaking out in this study as well, with the patient groups not being different from each other. So very, very interesting result there. And if we look at hemodynamics, again, no significant differences in heart rate at the ventilatory anaerobic threshold between any of the groups. And if we look at ventilation, some interesting things to look at here. There was a significant difference in minute ventilation, which is the volume of air cleared in a minute, as well as the partial pressure of carbon dioxide at the ventilatory anaerobic threshold. These are small differences, but they were statistically significant, and there were small interaction effects. However, in terms of partial pressure of end-tidal CO2, all tested within the normal range. So while it was significantly different, and there were some statistical interaction effects, all tested within the normal range. Respiratory rate, no significant difference. And then the last piece there at the bottom was more ventilatory efficiency. And again, significant main and interaction effects that were small, but all within the normal range. So testing within normal. So as far as ventilation is concerned, at the ventilatory anaerobic threshold, kind of a mixed bag of findings in terms of some things interesting from a statistical perspective, but from the perspective of comparing to normative data, it doesn't seem like anything that we would point to as a major driver of dysfunction. So again, what do we find? The group characteristics were similar in many of the important ways. The average RER suggested that participants all achieved maximal tests. And at maximal exertion, there were some small differences in VO2 and workload, but no significant differences in hemodynamic and ventilatory measures. At that ventilatory anaerobic threshold, there were moderate to large significant differences in VO2 and workload, as well as significant interaction effects. No significant differences in heart rate, and again, some statistically interesting findings in ventilation, but all were again within the normal ranges and very small in terms of effect. Um, so that's what we found. As far as what it means, we used a rigorous case definition to identify ME, and we did not use a rigorous case definition to identify people with long COVID. We sort of had all comers, physician diagnosed according to the National Academy of Medicine, U.S. National Academy of Medicine's case definition criteria. And yet, the findings from this study really appear to replicate 2-day CPET results that we see in ME/CFS. I don't think this means that all long COVID is ME/CFS, but I do think this argues for a shared pathophysiology in a great number of people with prolonged disability following long COVID. And I think some of these results are well supported by the metabolomics data that indicate widespread kind of metabolic and immune dysfunction in people with ME/CFS and long COVID. And I will note that findings from this study, which were larger and intended to fix some of the methodological issues associated with smaller pilot studies, did depart from some of those pilot studies that involved people with long COVID that didn't report PEM, mixed sex analysis, which in this body of work is a no-no, as well as interestingly enough, this data departed from other studies that documented breathing abnormalities and sort of breathing pattern dysfunction, and so it could just be that our participants. They may have had dyspnea, breathlessness, but they may not have, they just may not have had the same sort of clinical characteristics as some of those smaller studies. But a lot of those smaller studies, in terms of ventilatory characteristics, used non-validated measures of breathing pattern dysfunction, up to and including sort of visual inspection of plots, and sort of consensus criteria for getting raters to agree. And so using validated markers, measures of ventilation like CPET, I think has value in this population, especially for differential diagnosis. So again, CPET provides an objective, reproducible assessment of integrated cardiopulmonary, metabolic, and ventilatory function. And 2-day CPET really does seem to uniquely capture the pathophysiology of post-exertional malaise, which can be missed by a single CPET because you don't have a second measurement positioned, when the patient is symptomatic, in order to be able to capture the unique physiology that is happening there. So that 2-day CPET really does reveal that reduction in submaximal VO2 and workload on day 2 that seems to be rather characteristic of post-exertional malaise. And so 2-day CPET may be highly applicable to diagnosis as well as functional characterization to provide objective documentation of post-exertional malaise, identify which physiological systems are not playing nicely in the full body sandbox, and then also to improve the acuity of disability evaluation, establish pacing criteria, as well as to measure treatment responses, both on an individual level as well as in trials. So this is where I'll be quiet and kind of hand things back over to Staci for some summative remarks.
I'll I'll throw out some of the questions that are a little bit quicker, if we can tackle those real quick, and then we can hit some of the longer questions. One of the things I wanted to highlight is that not anyone can provide this cardiopulmonary exercise testing. So referring to just any group to provide 2-day cardiopulmonary exercise testing is not going to be usually very helpful for patients because of the interpretation and the understanding of what PIM is. So if you send to just anybody who does CPET, it's not usually a good idea. Can you comment on that?
Right. So we've been trying for years to get this test widely available and replicable, and unfortunately ends up being used against the patients. So cardiologists, if we refer to cardiologists, they look at the EKG. If that's normal, they say it's a normal test, even if they're meeting impairment criteria. And so I think the problem is physicians aren't trained in exercise science and function. And so for disability interpretation, it becomes very, very difficult. The second problem is PIM, understanding PIM. We've been interpreting these things for over 20 years. It's a learning curve and it takes time. And usually in the medical setting, they just don't have an hour to interpret the results. The other problem is in institutional settings, there's not a great deal of quality control. They assume that if you calibrate your equipment, it's reading accurately, and that's not the case. You have to do biological validation. Oxygen analyzers tend to drift high, and very, very few um, people that have metabolic carts actually validate that their equipment isn't working, and that's really important.
Great. Thank you for touching on that. I'm going to throw a couple quick questions and then we'll get to Dr. Brown. One is just, are patients off of their medications when they do the CPET? Like, do you tell them to, do they adjust their medications, or is it just stay on what you're taking?
We usually have them stay on what they're taking unless they're on stimulants. Or a lot of them come to us on beta blockers, and surprisingly, we still often get a normal heart rate response. If there's a blunted response, then we note that certain medications may cause a blunted heart rate response. Unless they work with their physicians to go off, we don't ask them to go off.
Okay. Another quick question. Does insurance usually cover, this is a question by Catherine. Does insurance
Mhm.
cover cover it? And then Jeffrey asked, and what is the cost of testing?
So we provide a super bill. We don't bill insurance as exercise scientists, but we provide a super bill so that you can bill in your own insurance. It usually covers something, but there's so many different policies. We just don't have the capacity to do that. Medicare reimburses. We're not a Medicare provider, but they reimburse $200 for the test. So unfortunately, at a Medicare reimbursement level, you can't even afford to maintain your equipment and pay your personnel. So you have to really almost be subsidized in order to do the test. We're charging $3,000 for the 2-day CPET. Um, yeah, these are fantastic questions. It's expensive to do well and maintain it and pay your personnel. So.
That makes sense. Dr. Brown, you have a question?
Yeah, fantastic presentation as always. Um, I love to see this data. So I'm actually trained in CPETs, because I'm a pulmonologist. Great. I think the biggest challenge is like Clayton, and you guys have alluded to, it's like you have to have a specialized center to do this. You have to have capacity to do it. Um, and then you have to have the analysis portion focused on that because we usually get like the, generic deconditioning chunk, and then like nobody really seems to go down much further than that. It's, the default is send them to physical therapy or whatever. But I think in obviously this case, that's bad, right? And then um my question is kind of getting to what you guys both alluded to, which is people actually having these tests used against them.
Mhm.
Because I think, for like pulmonary function tests, there are certain ones that are effort dependent, and there's not a good way to say the person just gave a crappy effort to some degree versus they couldn't give this effort. And so, how do you sort of respond to that criticism of like, this was just a suboptimal test that they just didn't do as good of an effort? and then do you spell that out for people? And because I think that's what I worry about is like somebody going to spend a lot of money for a test. They crash after their second day, and then their insurance or whatever still they were going to say no regardless, frankly. And so it was just another reason to say no for their disability.
So in terms of effort, respiratory exchange ratio is really, really hard to
Mhm.
fake, that relationship between oxygen and carbon dioxide. And so 1.15 is considered excellent effort. 1.0, the American Heart Association says is good effort. Unless people are on a ketogenic diet and we ask beforehand, it's really hard to get RER up on a keto diet and low carb diet. But otherwise, we don't have a problem. And in 17 years of doing that, well, we've only had one patient in 17 years not able to come back and do the second day test and give us a good effort. So we're pretty good at motivating them and getting what we need. And really, what's important is oxygen consumption at anaerobic threshold,
Mhm.
more important than peak because nobody can maintain peak for very long. Where we work and sustain work is at or below that threshold. So that we often get even if for whatever reason we don't get good peak values.
Okay. Thank you.
Yeah.
So another question we had from Jenny, where can testing be done? You had kind of talked about this, that it's hard. There's not very many centers that have the ability to do this. Like there's Betsy Keller and Workwell Foundation, and yeah, it's not super accessible because of the expertise required for the interpretation and quality control and things. So,
Right.
um, it, but it's you all use it a lot for disability and also research, but it's not like you can refer to anyone.
Those are the two I would recommend. We're in California, Betsy's in New York, and we really have labs specialized in just this. And again, I hate to hear stories of it being used against patients. And this has happened or they'll say, I did this test, can you interpret it? And we know the machine isn't working properly. Or I
Yeah,
had an invasive CPET, which is fantastic, but then they don't interpret it for disability purposes, and we know nothing about their quality control. Can you interpret my invasive CPET? And it's really hard to interpret tests from other labs when you don't know their quality control procedures. And 9 times out of 10, their numbers look really weird. Like they're all over, they look like they're not possible. And, when you have medical assistants running the equipment, they don't know, or even respiratory therapists, they don't have the background to know if their system is reading accurately or not and to troubleshoot that.
that makes sense. Thank you. Chandler, do you want to ask your question about analyzing oxygen kinetics and some of the things I don't understand as much? So I'll let you ask it.
Sure, yeah. I mean, Todd, I've talked with you a couple of months ago. I think you mentioned your team is going to be looking at the oxygen uptake efficiency slope. Any chance you're looking at excess post-oxygen, uh, excuse me, excess post-exercise oxygen consumption or EPOC in this population? See if there's any differences.
Todd, do you want to take that one?
Yeah, we haven't, and I can't remember. I think we might have discussed the first piece, but not the epoch. No, we haven't really looked at recovery as much. There's a lot happening with recovery. Obviously, we've part of the framing that I think has emerged from the 2-day CPET data is as an impaired recovery response. So I would not be surprised if there are some abnormalities there during recovery, but usually when you've asked someone to exert at that level, at the maximal level, the first piece is just getting them into a recovery position and helping them recover. So a lot of the physiological measures that we might do in someone who has some other kind of pathology or maybe is deconditioned, we haven't done as much of. But I do think that does sort of merit some additional intentional study.
Thank you.
We also had a question from Toby asking about calculating safe heart rate zones. I know you've mentioned that it's just it's all guessing because without the actual CPET. Is that correct?
Todd, you want to handle that one?
Yeah. Yeah, thanks for your question. So the best way that we found, obviously we're a little biased here because we're talking about 2-day CPET, and this is a two day CPET session is the heart rate at the ventilatory anaerobic threshold on the second of a 2-day CPET. Now, absent the 2-day CPET, we're in the realm of needing to shake the magic 8 ball and do some calculations. And these calculations, of course, are based on equations, and the equations are based on typical healthy folks for the most part. And so this becomes kind of a problem, especially when you have someone who not only may have chronotropic incompetence or a variable heart rate based on metabolic output, does not have a nice linear increase in heart rate with an increase in workload, but also may have orthostatic intolerance. So heart rate may just vary based on on body position. So it is possible to do that calculation and use the normal calculations, but you may need to sort of adjust that up or down depending on the patient, and that's fine to do. So the the calculations that we've discussed and have put forward really are a place to start. They're not intended as a commandment, so to speak. So feel free to adjust up and down. Now, I will say that people with infection-associated chronic conditions, ME, characterized by post-exertional malaise, may have a fluctuating dysautonomia, where their dysautonomia is better when they're having a good day or a better sort of period of time. So you may find that interference is less, and that calculation holds better when a person is on sort of a good swing. So just bear in mind that the dysautonomia piece is also not a stable situation. There may be fluctuations there that are meaningful. So again, tailoring to the patient becomes really important.
Thank you. Two more quick ones. So this one, Lynn had a question about before the CPET, resting up and pacing beforehand. Do you provide education about that to minimize the effects, or have you seen that do anything to minimize the PIM or not?
So we recommend our patients come in rested so that we capture that good day, bad day. We have preparation and recovery tips. I know in the multi-center NIH study that we were a part of, they recommended coming in rested. They did symptom severity scores prior to testing and then periodically throughout the recovery process. And ironically, patients in their day-to-day lives have higher symptom severity scores than they did coming into the CPET. So life for patients causes PIM, but resting is helpful going into it and pacing afterwards, planning for that.
Okay, thank you. Last question is from Jen Bell from Bateman Horne Center. Is the self-reported information that the patient provides included in the CPET report? I think what that's describing is their self-reported response and everything to
Yeah,
the test.
every report has a recovery section, both of the symptoms a patient reports and the days they report it takes them to recover. We also do a cognitive impairment questionnaire, and the results of that are also included. So those are the two qualitative pieces we include with the report.
Great. Thank you so much. I think we got to the majority of questions, and I can see that Todd responded to a bunch of them in the chat. So I'm so grateful that y'all came and shared your knowledge and expertise with us. For those attending, thank you all for joining. Don't forget to claim your CME credit. And then our next session will be on neuroendocrine dysfunction in ME/CFS and long COVID next month. So we'll see you then.